The main focus of my talk here this morning is I became involved in the development of one of the national clinical care guidelines on the topic of resuscitation for the pregnant woman. So I'm just going to go through how we developed the guideline and the information contained within it. Hasn't been published yet, but hopefully it'll appear in the near future on the Institute of Obstetrics and Gynecologists website and be distributed to the hospital groupings. So I'm just going to go through the purpose, the scope, and the methods for the guideline, just to recap on some of the physiological changes of pregnancy. Then I'm going to go through a discussion on maternal cardiac arrest and the causes and management, and then go through the areas of implementation and governance related to the guideline. So the purpose and scope of the guideline is to provide evidence-based guidance to healthcare professionals involved in the management of the pregnant woman who has developed a cardiac arrest. So maternal collapse is defined as an acute event involving the cardiorespiratory and cerebrovascular systems, which results in a reduced or absent conscious levels at any stage in pregnancy and up to 6 weeks after delivery. So you could probably further subdivide this into the collapsed patient who is responsive, the collapsed patient who is unresponsive, and then you could further divide this again into the patient with or without a pulse. So the main focus of my talk this morning is going to be on this last group, the woman who has developed a cardiac arrest who does not have a pulse. So the incidence of maternal arrest, obviously this is a very rare event, so determining the true incidence is difficult. But the best data that we have comes from a couple of sources. Probably the best data comes from the UK Confidential Inquiry. So for the years 2003 to 2011, the incidence is estimated at approximately 1 in 20 to 30,000 pregnancies. So based on that ratio, we should expect to see a couple of cases of maternal arrest every year in Ireland. In fact, we had one last week in Holles Street. More recent data from the United States, which covers the years 1998 to 2011, published in Anesthesiology earlier on this year, they give a ratio of approximately 1 in 12,000 cases per hospitalizations for delivery. So it's a slightly different denominator compared to the UK data. This US data comes from a database that was designed to capture a representative sample of approximately 20% of all US hospital admissions. So it's a huge database covering almost 57 million patients. Of note from the US data, approximately 59% survive their cardiac arrest to hospital discharge. So just to recap a little bit on the physiology of pregnancy, multiple changes will occur both during the pregnancy, and these occur to meet the growing needs of the growing fetus and the placenta. So the cardiovascular changes that occur, we have an increase in blood and red cell volume, approximately 35%. You get a larger increase in plasma volume of 45%, and the result of that is you have an overall dilutional anemia. You have an increase in stroke volume, that is the volume of blood that's pumped out by the heart every time it beats, of approximately 30%. You have an increase in heart rate of up to 15 to 30%. And the result of this increased heart rate and stroke volume is that you get an increased cardiac output of approximately 40% at term. So to accommodate all of this extra blood being pumped around the body, you have a vasodilatation, you have a decrease in the systemic vascular resistance to accommodate all the blood. The result of that is, although you have a slight change in diastolic blood pressure, the blood pressures by and large remain more or less the same as at pre-pregnant levels. So moving on to respiratory physiology. So we have an increased oxygen consumption of up to 20 to 50% at term. This is partly achieved by increasing minute ventilation. So the minute ventilation is comprised of tidal volume, which is increased, and also the respiratory rate, which is increased. So this results in we have an increased oxygen demand with a decreased oxygen reserve. So the FRC is what is known as the functional residual capacity. it's a physiological parameter. It basically means the volume of gas left in the lungs at the end of normal expiration, and this volume of gas works as a store of oxygen, and this is actually reduced in pregnancy. So the bottom line here basically is that you have increased demands for oxygen and decreased oxygen reserves in a pregnant patient. So obviously they're going to desaturate very, very quickly. So some of the causes for maternal arrest. So I've taken this mnemonic from the American Heart Association ACLS guidelines. So it's both chops. Okay, so I'm just going to go through them. It's a useful way of listing off all of the causes. So B is for bleeding or disseminated intravascular coagulation. E is for embolism. A is for anesthetic complications. U is for uterine atony. C is for cardiac disease. H is for hypertension, including preeclampsia and eclampsia. O is for other causes not mentioned already. So that's the standard differential diagnosis of a cardiac arrest, which would be the 6 H's and T's. That's hypoxia, hypokalemia, hyperthermia, hydrogen ion acidosis, hypoglycemia, and for the T's, tension pneumothorax, tamponade, toxins, and trauma. P is for placental abruption or previa, and S is for sepsis. Excuse me. Okay, so just moving on to deal with the actuality of maternal collapse. Okay, so this algorithm you may recognize is from the RCOG Green Top Guidelines on maternal collapse. So I'm going to go through most of the details on this contained in this algorithm over the next few slides. This is also a useful item. It's a checklist which details all of the important steps involved in managing a cardiac arrest. And I think that it's a good idea to have both a copy of an algorithm, whether it's the RCOG one or not, and also a copy of a checklist like this attached to the resuscitation trolley in your maternity unit. This ensures that you're not going to forget any of the important steps. Okay, so if you have a patient who's collapsed and unresponsive, first thing to do, you're going to check does the patient have a pulse or not. If the patient has a pulse, turn the patient onto their left side, measure the blood pressure, and take it from there. If the patient doesn't have a pulse, we're dealing with a cardiac arrest situation. So you're going to activate the emergency response team and commence basic life support. Basic life support is now comprised of compressions, airway, and breathing. It used to be ABC, it's now CAB. So the resuscitation team should comprise the locally agreed adult medical emergency team. It should include an obstetrician capable of performing caesarean delivery, and the neonatal team should be called early if delivery is planned. So for a standalone maternity unit, the resuscitation team would probably have all those people on it already. In a general hospital, it might be slightly different, so it may be necessary to create a specific code for a maternal cardiac arrest so that appropriate personnel arrive, i.e. the obstetrician and the neonatologist. Moving on to chest compression. So these should be performed at a rate of 100 per minute to a depth of 5 to 6 centimeters. Important to remember that you place the heel of your hand approximately 2 to 3 centimeters higher on the sternum in the third trimester. There should be no interruptions to the chest compressions if the airway has been secured with an endotracheal tube. If the airway has not been secured with an endotracheal tube, the ratio is 30 compressions, then a brief pause where you administer 2 breaths, and then continue back on with your 30 compressions at a rate of 100 per minute. So it's recommended that the person doing the chest compressions should change every 2 minutes, because if you're doing it effectively and at a rate of 100 per minute, it's actually very tiring. The ACLS guidelines also recommend monitoring of exhaled carbon dioxide as an indicator of compression effectiveness. What this means basically is that if you're doing effective chest compressions, you're managing to pump blood around the body, you will have and create an artificial cardiac output. There will be carbon dioxide exhaled from the lungs, And if you're measuring this, it's an indicator of how effective your resuscitation is. Moving on to left uterine displacement. So as we all know, the gravid uterus may cause aortocaval compression. This is generally deemed to occur if the uterus is palpable at the umbilicus, or greater than 20 weeks gestation, but may occur earlier than this in scenarios such as polyhydramnios, multiple pregnancies, etc. Important to note that compressions are most effective if the patient is lying on a hard surface. If you manually displace the uterus to the left, and like the use of wedges and pillows, etc., the compressions are actually not as effective as if you manually displace the uterus. Okay, so just have a diagram illustrating that. So you've got somebody standing on the left-hand side of the patient who's manually pulling the uterus up and away from the inferior vena cava and the aorta, and this is the most effective way of applying left uterine displacement. For defibrillation is the most effective treatment for ventricular fibrillation. So there are standard defibrillators, or what's called automatic external defibrillators, or AEDs. So AEDs may be useful in situations where people do not have rhythm recognition skills. So it's but whatever you have in your own unit, be familiar with what type of defibrillator it is and how to use it. You'll only interrupt your chest compressions to assess the rhythm, and if the patient is in ventricular fibrillation, you apply a shock of 150 joules for the adult. For airway management, you'll apply simple maneuvers such as head tilt, chin lift, and jaw thrust. These will help to open up the airway. You may then insert an oropharyngeal or Guedel airway. Again, that helps to open up the airway. You're going to apply bag mask ventilation until you get a visible rise of the patient's chest. Laryngoscopy and intubation should only be performed by experienced personnel. Similarly, supraglottic airways, for example, the laryngeal mask airway may also be used, but again, only by experienced personnel. So the main point I'm trying to make here really is that the focus should be on oxygenation and ventilation of the patient by whatever means. So if you're managing to bag mask the patient adequately, then you're doing that's all that's expected of you, really. And people shouldn't get focused and bogged down in trying to intubate the patient instead of trying to ventilate them. As we know, the pregnant patient is at risk of gastric aspiration. So this may occur when gastric contents passively move from the stomach back up the esophagus and into the airway. So the application of cricoid pressure may reduce this risk. So for those who are not familiar with cricoid pressure, it's basically pressure applied to the cricoid cartilage, which is just underneath your trachea. And by applying pressure on the cricoid cartilage, the idea is that you compress the esophagus, and thereby you reduce the chance of gastric contents passively regurgitating up along the esophagus. Obviously, if you don't do this correctly, you may actually obstruct the airway, and you make it very difficult for someone to ventilate the patient. So again, although it's a relatively simple procedure, if you haven't been trained how to do it, you probably shouldn't be doing it. So again, it's something that probably should be, or something that needs to be taught. Just moving on to perimortem cesarean delivery. So the guidelines support the rapid delivery of the fetus in the setting of aortocaval compression. So the logic behind this is that if you empty the gravid uterus, you're going to improve venous return back to the heart, and you're going to improve the chances of successfully resuscitating the patient. Okay, carrying out the perimortem cesarean delivery should occur if there is no response to advanced life support measures, including adequate left uterine displacement. So there's no point trying to do a perimortem cesarean delivery if you haven't been effective in your manual displacement of the uterus. So as I mentioned earlier on, someone's on the left-hand side of the patient manually displacing the uterus. The aim is to deliver the fetus at 5 minutes, although maternal and neonatal survival have been reported with longer intervals of arrest. The recommendations are that you would perform the perimortem cesarean delivery at the site of the maternal arrest. So don't waste time trying to move the patient to the operating theatre. Wherever the woman collapses, if perimortem cesarean delivery is going to be carried out, it's carried out there and then. So what this means, of course, is that every resuscitation trolley in your hospital should have a surgical pack for cesarean delivery. So this perimortem cesarean delivery is a slightly controversial area. Sharon Enov and colleagues published a review in 2012 of 94 published cases where they deemed that data was deemed adequate for analysis. Obviously, this is a very rare event. Of the 94 cases that they studied, 54% survived to hospital discharge. They deemed that perimortem cesarean delivery was beneficial for 32%, that the condition was not worsened in any of the patients. Of note, in only 4 of the cases was the baby delivered within 5 minutes. Obtaining intravenous access is a very important part of the resuscitation scenario. So each unit should have equipment for the rapid delivery of large warm fluid volume. Ideally, you would give fluids above the diaphragm. This is to prevent the effects of aortic cable compression, well, in particular, vena cava compression. Each unit should have a massive hemorrhage protocol, as Brigitte was alluding to, and every unit needs to have rapid infusers, should have an ultrasound for obtaining central venous access, and every resuscitation trolley should have intraosseous needles for the situation where you fail to get IV access. So again, if you haven't seen or used an intraosseous needle before, it's actually quite straightforward to use. But again, there needs to be a certain amount of training in how to use these devices. For resuscitation drugs, I'm not going to go into all the details of the drugs, other than to say that it's the same drugs and doses are used as for the non-pregnant patient. I will just mention one thing which may not be familiar to everybody here, which is the use of lipid emulsion. Again, this should be available on all resuscitation trolleys, and lipid emulsion is used for the treatment of local anesthetic toxicity. And again, this is the situations where something like this is most likely to occur is on an obstetric unit. For the post-resuscitation, or even as part of your resuscitation, so you're going through your basic life support, your advanced cardiac life support, and as part of the resuscitation process, you should be thinking to yourself, what are the potential causes for this cardiac arrest? As I mentioned, the useful mnemonic earlier on, both chops. You should probably be working through that in your head, thinking of potential reversible causes. For example, pulmonary embolus. Should you be anticoagulating this patient? Is a pulmonary embolus a likely cause? Now, again, this is probably beyond the remit of my talk today. There are so many potential causes, but it's just useful to, at some point in the resuscitation scenario, you need to think about what are the potentially reversible causes. There should also be a defined pathway for the transfer of a successfully resuscitated patient to the intensive care unit. And there's been a recently published guideline which was created in conjunction with the national clinical programs in anaesthesia, critical care and obstetrics, indicating how this should be done. Also, post-resuscitation measures, for example, therapeutic hypothermia, are beyond the remit of this talk, other than to mention them. Okay, so this is the guideline that I just mentioned. It's the guideline for the transfer of for the care of the critically ill woman in obstetrics, and the protocols for transferring patients from one hospital to another, depending on the level of care required. So, what are the measures for quality improvement in relation to implementation of this guideline? So the recommendations would be that there's a designated lead person for resuscitation in each maternity unit, that all clinical staff should have adequate and up-to-date resuscitation skills, that all cases of maternal collapse should be reviewed through a clinical governance process, and that there should be periodic emergency drills within the hospital involving members of the from departments of anaesthesia, obstetrics, neonatology and midwifery. So I've just asked the question, I suppose the aim of this conference today is try to determine how are we going to deliver standard multidisciplinary training across all of these like emergency scenarios in every maternity unit in the country. And I've just put a few questions up there really because I don't know how are we going to do it, but should we provide basic life support and training locally? Should we be doing something along the lines of the UK prompt style courses? Should we be doing multidisciplinary simulation laboratory sessions? There's a very good simulation laboratory in the College of Anaesthetists here in Dublin. I know that the anaesthetic departments of some hospitals around the country, including Cork, Galway, and some Dublin hospitals, will also have simulation labs which may be useful for providing this kind of multidisciplinary training. It is also possible to get pregnant mannequins, and these will simulate uterine contractions. You can do CTG monitoring, you can simulate breech and instrumental delivery, shoulder dystocia, hemorrhage, etc. They're actually very good if anybody hasn't seen them. So for any clinical scenario you want to look at, what are the key performance indicators, as in how are we managing this scenario in our unit, and how do we compare it across other units both nationally and internationally. So there's obviously, in dealing with a complex scenario like a cardiac arrest, there's a multitude of contributing factors and interventions related to the scenario. But for cardiac arrest, you can break it down into their kind of three main key performance indicators, which would be early defibrillation, effective chest compressions, and adequate oxygenation of the patient. So what's known as Utstein reporting templates, these are what's recommended by the American Heart Association, European Resuscitation Council, etc. They recommend the collection of a multitude of data, but I mean, some of it is, it's almost too much really. But the most important data to collect when you're trying to benchmark yourself is the time from the patient collapses to the first attempt at CPR, the time from the patient collapses to the first defibrillatory shock, if appropriate, and also I think we could add to that the time from collapse to the time for perimortem cesarean delivery, again, if it's appropriate. So I've been asked to provide a take-home message. So just in summary, each obstetric unit should have a designated lead person for resuscitation. All healthcare providers within the unit should have adequate and up-to-date resuscitation skills. Standard adult resuscitation protocols with the addition of left uterine displacement are applicable to the pregnant woman, and perimortem cesarean delivery in the setting of aortic caval compression should be performed as soon as possible, ideally within 5 minutes, if there is no response to adequate resuscitation manoeuvres, including left uterine displacement. That's a thank you.